And we're going to move on. Our next panel is on testing and linkage to care as gateways or closed doors to successful HIV control. Our moderator is Dr. Jorge Saavedra, who's the Chief of Global Affairs for the AIDS Healthcare Foundation, and he'll introduce the panel.
Thank you, Ken. So I'll ask the panelists to come, and I will keep it short. We have only 45 minutes for this panel, so that includes the presentation and the discussion from the panelists and also sometimes for the audience. So our presenter is Wafaa Al-Sadar. She is the Director of International Center for AIDS Care and Treatment, ICAP, and Director of the Center for Infectious Disease Epidemiology Research at the Columbia University. So I'll give her the floor, and then I will introduce later, after her presentation, the panelists.
So good afternoon, everyone, and thank you very much for the opportunity to present. I think inevitably there is substantial overlap between what you just heard from Meg Doherty and her really tour de force presentation on the cascade. But nonetheless, it's good to hear things once and once more. But just to let you know that my goal is really to focus on, I'm wondering which is the pointer here. Maybe there is no pointer. Okay. My goal is to focus on testing and linkage only. So that's just one part of the cascade, not the full cascade. So I'm going to just be focusing on that. So here's a brief outline of my presentation. First, talk a bit about how are we doing in terms of testing and linkage. Then move on to what are promising approaches that are available. And then opportunities and challenges, and then the way forward. So you've seen already different kinds of slides of the HIV care continuum. And as you can see here that, again, it's from testing all the way to adherence and viral suppression. And my goal is to focus just on that. I'm sorry, it's hard to do without a pointer, but on testing and on linkage alone. So it's the left side of the cascade. And that's a component of the cascade that's actually very understudied, as Meg already mentioned to you. 5 pounds an hour, that's not bad. Thank you, David.
Technical assistance, David.
A true teacher who travels with his pointer. So this is the testing and the linkage, and that's my focus today. And I think I want to convince you that this is the foundation of the whole cascade. And when we studied substantially this side of the cascade, we haven't really given as much attention to that part of the cascade, as was indicated by Meg as well. So how are we doing in terms of testing? First, these are nice data from Kenya, from KAIS, the national survey. And what it shows is that, again, from 2007 to 2012, there's been some substantial improvement. And for example, amongst people who are aware of their HIV status, you'll see that there was a decrease in those who were reported that they were unaware of their HIV status. But nonetheless, more than 50% still reported they were unaware of their HIV infection despite being HIV infected. Another piece of data that's important, why is it important to know one's HIV positive status or one's HIV status in general? And these are data from Swaziland, from the national survey that Debbie Burks mentioned that we conducted, ICAP conducted in partnership with the Ministry of Health and with support from CDC. And in that survey, which is a household national survey, about 24,000 household members were eligible, 18,000 participated in the survey, and a substantial proportion here, 32% were HIV positive, and I want you to focus on those who are HIV positive. And from this slide, the next slide, you'll see that if you look at the mean viral load amongst the total population of HIV positive individuals versus those who were unaware of their HIV status and those who were aware of their HIV status, you'll see that it's much higher in those who are unaware of their HIV status, meaning, of course, the risk of transmission to others, and so on. And if you looked again amongst those who are aware of their HIV status, of course, not surprisingly, those on ART have much lower viral load than those who are not on ART. What about linkage? Linkage, the next step, critical step. These are data from Rwanda, actually, where which has a country that has a very strong HIV program in general. But as you can see again, that 42% of those who are identified to be HIV positive were enrolled within 90 days. Meaning even in this very strong program, there's still huge deficits in the linkage piece of the cascade. And these are more data. This is from Mozambique that look at, again, linkage and demonstrate, again, the problems in terms of linkage of those who are HIV positive, particularly what's, I think, the take-home message from this slide, particularly amongst those who are tested in PMTCT setting, where there's a much lower linkage of the women who are HIV positive, demonstrating, of course, what we've talked about earlier today, the deficits in linkage, but particularly, of course, amongst pregnant women. And why is this important? The whole idea of testing and early linkage is because we have the major problem of low CD4 at engagement in care. And these data are actually in developed countries, not even in developing countries. And the mean CD4 over time, and you can see again, that's pretty low. There's been an increase, but nonetheless, it's in the 300s. And that's in developed countries versus developing countries. So we have a long way to go in terms of testing and linkage. So what are the barriers quickly to testing and linkage of HIV-positive individuals? Of course, unaware of status, disenfranchised, stigmatized populations, fear of discrimination and stigma, unaware of the benefits of knowledge of status, limited access. I think very importantly, we didn't talk about that today sufficiently. I think provider bias and provider practices that can often really turn people away from the services. And lastly, of course, the unwelcoming services for some populations. In this slide, just the message from this large review is that the most common reasons that have been cited were deficits in terms of linkage or failure to link have been transportation costs, stigma and disclosure, and clinic-related factor. This is the part about the respect by the providers and the welcoming attitudes in the clinics themselves. So what are the types of interventions that have been looked at in terms of testing and linkage? And very quickly, just to give you a few examples, of course, there are both structural and behavioral interventions that have been tried. I'll focus on a couple that have been much more in the literature, and those include home-based testing and counseling, as well as community-based counseling and testing, self-testing, and those are the ones that I think I'll focus on. There's, of course, provider-initiated testing and many, many other types of testing endeavors, but I'll focus on the ones that have been the focus of attention recently. And this demonstrates something that came up earlier, is that there's high uptake of community HIV testing and counseling, meaning going to where the people are at in the community, whether it be door-to-door, workplace, school, etc., mobile units, is that there is a large uptake of testing and counseling when there's outreach into the community in a variety of different settings. Of course, there are lots of issues about the cost, especially if you have to repeat the testing every 6 months to 1 year. Substantial cost, of course, in going door-to-door and doing the testing. Quickly, again, this is one endeavor in Kenya where they tested a large number of population here, more than 150,000. They had very good uptake of testing. They had substantial numbers of adolescents, young adults, high acceptance. But what was interesting that people who were less likely to accept testing if they'd been previously tested, but then those who accepted testing in that group actually turned out to be much more likely to be positive. So this highlights the importance of retesting individuals as an important part of the challenge. I think, again, provider-initiated testing and counseling is very important, and it's been shown that, of course, provider-initiated counseling and testing often enhances the linkage thereafter because often they're co-located where the testing is being done and where the care is being done. HIV self-testing was raised by Meg again, and I think it's been shown in some studies, as well as there's been a review published, that it's acceptable, and that actually the population is pretty good at actually doing it accurately, and that was quite acceptable. So it offers new opportunities for testing. What about improving linkage? That's, again, another Achilles heel of the cascade and an important one. Some strategies have been tried, particularly co-location of services. Obviously, that makes it easy if you're testing and provide the care in the same setting. Decentralization of services has made a big impact, and I can remember, for example, in ICAP-supported sites from the early years, about 10 years ago, to now, there's much more decentralization going from tertiary facilities to secondary facilities to primary facilities, going from urban to peri-urban to rural areas. So decentralization has helped. Use of peer educators has also been tried, as well as referrals after home-based testing, and then the whole issue of point-of-care CD4 testing. I don't have time to go through this, but there have been several studies that looked at peer navigators, and they demonstrate that peer navigators were superior to controls in terms of enhancing the linkage of individuals from testing to HIV care. A point-of-care CD4 testing has been studied extensively, and the data look quite promising. If you look at the linkage here from point-of-care testing versus standard of CD4 count, and there's always an improvement in terms of the outcomes. So I think this is also another promising strategy to enhance linkage, that Achilles heel in the cascade. Quickly, what are some unanswered questions? I think there's ongoing research to try to look at the continuum of care, and also research that's looking particularly at those two vulnerable points, the testing and the linkage. So there's a study that's ongoing now by the HPTN, called HPTN 065 in the United States, and that's looking at social mobilization and testing at facilities to enhance testing, and it's utilizing financial incentives to see if financial incentives given to those who are positive can enhance linkage to HIV care. The study is also intervening, provider training to initiate ART, and financial incentives to enhance viral suppression. So I think the message is that the studies that are ongoing now are really looking at the cascade and trying to intervene at the cascade and multiple points, which I think is the way to go, rather than focusing on one intervention for adherence, for example, and not keeping in mind the other antecedent parts of the cascade. Another large HPTN study, HPTN 071, the POPARD study, is being conducted in South Africa and Zambia, 21 communities, a population of 1.2 million, and that's co-chaired by Richard Hayes and Sarah Fidler. Sarah is here, and Richard is here, or will be here tomorrow. And that study is also a multi-component intervention study, focusing on home-based testing, using community workers to enhance linkage, universal ART, and using the community healthcare workers to also assist in retention and adherence. In addition to the focus on the HIV positive cascade, in that study it's also focusing on the negatives and trying to link those who are found to be negatives through the household testing to link them, for example, the men to male circumcision as another intervention. In addition to these large clinical trials, they're either looking at the feasibility of intervening at every step of the cascade, or 071, which is really looking at the ultimate efficacy of treatment as prevention, because it's powered for HIV incidence in the communities. There's also been interest in implementation science, and I want to sort of focus on two things. One is the importance of studying how to implement, but I think also very importantly, the need to study how to scale up. I think they're different. The study of implementation is different from scale up, and I think both of these need more attention as we move ahead in terms of identifying the gaps ahead of us. We're doing several implementation studies, and you can see from their names that ICAP is doing, Link for Health, MIR for Health, Engage for Health, and all of these are really trying to intervene at various parts of the cascade. So way forward, I thought just to get the panel discussion moving, to put across some thoughts and ideas to generate maybe a discussion. I think very importantly is that we need to go beyond what I call the tip of the iceberg. Is often in our interventions we're thinking of intervening with the people right in front of us, or the people who come to seek our services, or the people we find to provide services for, and we often forget the people right under the water level here, the major part of the iceberg. And that's really what population health is all about, is really trying to reach the population at risk as a whole. So that's important, and I think challenges us all to move beyond our programs and move beyond our clinics and think about how can we demonstrate an impact at a community level by going after the whole iceberg. The other issue is being smarter, as was mentioned earlier today, and especially in terms of testing. And this is just a slide of work we did in Lesotho, a country with very high HIV prevalence, where you can map the prevalence in men and women geographically, and that can help you focus where you want to focus your attention in terms of trying to do expansion of testing. And you can see here in one district, you can map exactly within the district where the hotspots are, so you can focus your efforts at reaching the population that's most likely to have the highest yield of individuals that are HIV positive. Another thought, I think, is the importance of what we call no partial credit, meaning that often programs are evaluated based on how they perform on one part of the cascade, how they're doing in terms of retention, how they're doing in terms of testing, but not really across the continuum. And this concept of no partial credit is important as we move forward and try to reach beyond, again, to reach the populations. We need to think of how programs are performing all along the whole cascade without providing partial credit for performance in one only piece of the cascade. I think Meg showed this again, the side door concept, which means that people, and in the context of testing and linkage, it's important we always think of people who are newly tested and how we're going to link them. I think what's very important to also think of all the people who are positive, who haven't linked, who are out there in the community. We don't think of them for linkage. We're trying to always start from the people who are under our nose that we have tested through the programs. And this side where the people who have been tested, who are positive, who have not linked, who are out there in the community, are a very important part of the population that needs to be reached through different strategies to try to link them into our care systems. And I think one other issue is this paradigm shift focused on HIV prevention continuum that Meg focused on a bit, is that similar to care and treatment. I think when we do testing, most people that we test will end up being HIV negative, and often these individuals don't get much attention, whether they be in antenatal clinics or any other clinic. The negatives really get very little attention, and they should get more attention. And the idea that every individual who's negative needs to be engaged in his or her own cascade, the prevention cascade, is very important, whether it be using condoms or PrEP, whatever the intervention is, and then they need to be supported to adhere to whatever the intervention is and to be monitored and to get repeat testing to identify seroconversion, and then they would go from the negative cascade to the positive cascade. And lastly, I think there are many opportunities and challenges, as I've shown you, I hope, is that testing is the foundation of all HIV-related programming. There are multiple approaches that are available. I think there's a need to use multiple approaches, not just one. I think they need to be adapted to specific population. I think, again, there's importance to also make sure that to aim for high coverage, to try to reach the population as a whole, rather than aiming for just reaching numbers of tested. And then the linkage is a critical missing link in the chain, in the cascade. And there are many different interventions that have been tried, but there's a lot of work that needs to be done to understand better this part of the cascade. And lastly, I just want to remind people of one other important piece of the cascade that's often forgotten, which is the issue of quality. Quality is very important because you can achieve coverage, but if you have poor quality, you won't have any effectiveness of your intervention. So I think quality is an integral part of the cascade in order for us to achieve what we ultimately want to achieve in terms of the outcomes of our programs. Thank you very much.
Thank you very much, Wafa, for this interesting presentation, also all the data that you're sharing with us, and the interpretation of that data as well. So I will introduce briefly our panel. First is, I would like to introduce James McIntyre. He's the Executive Director of the ANOVA Health Institute, an independent nonprofit health research and technical assistance organization based in Johannesburg, South Africa. Then next to him is Kenley Sikewes. He's also a long-time HIV activist from Zambia. He is the coordinator of the African Community Advisory Group. We also have Rupert Whittaker, based here in London. Rupert is a psychiatrist, immunologist, and also he's the founder of the Tuke Institute, an international organization researching the health effectiveness of medical services. And last but not the least is my colleague Terry Ford, a long time also HIV activist, 24 years, and she's also implementer because she's implementing rapid HIV testing on a massive scale in different countries. So I will start with the last in terms of asking the questions. So according to the WAFA's presentation, Terry, there was a lot of ideas and experiences on how to increase testing, but your experience is doing on this massive testing in public places. So what will be the willingness of people to get tested in a public place instead of getting tested in an HIV facility or a clinic or maybe a hospital? So what will be your experience on these terms?
Oh, thank you. Well, we launched the 1 million test campaign in 2008 in order to kind of crash the VCT model so that we could test people faster. And what we saw was people came in droves. We took the tents away, we opened it up, and we actually test in the open. In 2007, I remember distinctly NACO in India telling us not to bother trying to test women in India because they're not going to come. So just focus on men. And we said, well, no, we're not going to give up on women. We're going to try. And the first event we had, women lined up. We have these incredible pictures in their saris with their children, hundreds of them on the first day, completely opposite of what the National AIDS Control Organization, predicted. So we have to remember that sometimes we create the stigma in our minds. We didn't, when we open up the testing, in Mexico City, in Estonia, in Cambodia, all over there, in Zambia, people come and test in the open. It's there's so much talk about the stigma associated with people coming to get tested, and we haven't seen that. So I think that you have to try, you have to make it as convenient as possible for people to come, and they will come. The demand is there.
And thank you, Terry. The next question is for James. Going from the testing to linkage, James, according to WAFA, there are also several options of linkage to care depending on the populations and the settings. Will you see any kind of standard recommendation that is successful in terms of linkage to care? I know that this is very difficult, but in order to achieve the second 90%, we need linkage to happen in a very, I won't say massive way, but in a very effective way. What will you think about this part?
I think it's quite difficult to have a standard recommendation other than a physical one, which is the closest you can get that linkage to that time and place of testing, I think, is the better. And I remember, I'm sure it was an EGPAF presentation many years ago, it talked about the number of doors that mothers had to go through between having a test in an antenatal clinic and getting nevirapine at that point. And the more doors, the less likely it was that would happen. So I think the standard is quite difficult. I think there's a number of groups that concern me even more, though, about linkage, and it's men in general. When we talk about prevention, we talk about the need to get to young women, but if we're going to use treatment to prevent new infections in young women, we've got to get men onto treatment. And men in the southern African setting, at least, don't get tested and don't get linked into care. They don't have that clinical exposure. So I think, for me, that's a huge challenge. We know that 2/3 of people on treatment in African settings are women, and we're missing the men. So I don't think we're going to get the prevention benefit unless we do that. And that's men in general. That's not even allowing for MSM and the communication and stigma barriers that Meg referred to that we know are there within healthcare services. I think the advent of self-testing and home testing are both very good interventions. I really worry about how they link, and I think the challenge is to use the momentum that we can get for testing by using those new approaches, but ensuring that we don't miss the linkage back into care. And that means making sure that health services are welcoming and are efficient and are competent. The line we take with our MSM program in South Africa is that it's not enough to be MSM friendly. We don't want friendly, we want competent. And I think that applies right across the board.
Yeah, and I have another question for Kenley. Kenley, how the willingness of communities affected by HIV or being promoters of testing or the best vehicles for linkage to care, how do you see the role of communities on these two aspects that WAFA described in terms of testing and also in terms of linkage to care?
Thank you very much. I think what we one of the first things I did in Zambia was actually to be a testing, what do you call them again? Counseling and testing counselor. And what we found was that, one of the things that I discovered was that if you use community mobilizers to mobilize communities who would sing songs and dance to demonstrate what testing has done for them and why they are alive, because they're tested and they know their status and they're on treatment, that increased the uptake of services, or testing services. And obviously, because we are beneficiaries or are alive today, because we know our status and have treatment, and especially as you can speak about treatment, that in itself motivates would-be testers or the community at large. But in terms of our willingness, that is a hallmark of what we live for, is to encourage people and many, many more people to know their status, not only just for the prevention of HIV, but they're also alive to stay, well, maybe long enough to, to enjoy the benefits of a cure. So yes, we are definitely very willing to support testing, and we do support testing services.
Thank you, Kelly. Rupert, WAFA mentioned that doing testing at the point of care will dramatically improve linkage to care. But probably she didn't mention about the self-testing. Do you think self-testing can be a barrier for effective linkage to care? Because self-testing, I think, is the farthest part of getting testing on the point of care, because it's at home.
Yeah, exactly. Can everybody hear me? Thank you for your presentation. The self-testing issue is still alive, even though it's a sort of a failed battle in a way. I think there are a lot of problems with self-testing, and I think that it's the larger context of the self-testing problem is around the relationship with health services. If I can sort of refer to that cascade of care, as a gay man with HIV for over 30 years, it doesn't mean much to me. And that is, it's true. What that cascade says is very true. It's obviously accurate. But it's not, it doesn't mean much to me about my health and my daily challenges. And if I were negative and I was self-testing and having high-risk behaviors, say, or in a high-risk situation, the thing I think that would make the difference is knowing that I can link to a health service anyway, whether or not I'm positive or negative, that I can trust and that actually speaks to the larger picture of my health needs. So we're talking there about the meaningful engagement with health services. And the problem here, and I see it in a lot of the presentations, is around a physician-centered model, not a patient-centered model of the health services. So if there is going to be meaningful engagement after self-testing, it's going to rely on people trusting the services and knowing that they're going to speak to people's overall health needs, not just HIV or hepatitis C, but STIs, mental health particularly, and social inequalities. And I've been a patient in at least 5 countries over this time. And for instance, the NHS has got a very well-reputed system, but I think it's also one of those that is in the greatest need of betterment. Because of these issues, it's about a physician-centered model. Now, I think that if you are going to have self-testing, then the only way that you're going to actually increase that engagement and that meaningful engagement is by learning the lessons of the 80s and 90s, which is that you can't do for the community. You have to do with the community. And Kenley's point was very apposite in that respect. So you have to empower the community to be part of the service. And we're not getting that nowadays in Britain, for instance. And I don't see it much in the US either. I hope that's addressed the issue adequately.
Okay, thank you, Rupert. And before asking the panel to react to some aspects that probably I haven't touched about Wafa's presentation, I would like to ask Wafa something that, well, she mentioned it, testing and counseling, and I like it very much that way. But usually the standard is VCTs, voluntary counseling and then testing. That means that the VCT, the old VCT model that was, developed when there was no treatment, when there was a need of waiting for 1 or 2 weeks to get a result, probably that needs to be changed because it talks about voluntary counseling and then testing at the end. And probably this way of voluntary testing and then counseling could be more effective now that we have this technology and that the rapid testing technology is here. So I don't know, probably some people, mainly in massive testing or when there are a lot of people wanted to get tested, just waiting for a counseling for each one of the people who want to know their status might be a lot of not just time consuming, but also cost. So, but you mentioned it, testing and counseling. So what do you think about changing that model?
I think the issue is that I think the word voluntary needs to remain, is fundamental to any type of testing. I think it's kind of unfortunate that it's been linked to one type of testing, which is the model where the traditional VCT, which is a freestanding testing site, often not in connection to a service where people came to be tested. And so that's kind of the traditional one. I think that's the model that's now the evidence. So I think the word voluntary is very important to be intrinsic to any type of testing that we do. It's implied, I hope, it's implied that it is a voluntary process. That's very, very important. I think the other issue is there are a variety of different ways of making the counseling and testing or testing and counseling be more efficient. And I think part of it has been because of now the balance of the benefits of knowing one's status versus 15 years ago, it's just kind of tipped to there are many, many good reasons for knowing one's status, whether it be for individual benefit or for societal benefit. And that's the reason why I think people have moved away from the traditional 1 hour of counseling and testing where you tell people about all the horrible things that can possibly happen to them from testing to more of a balanced and more of a streamlined where testing is is presented upfront. Going to something else that was, I think you mentioned, I think we should really try to stay away from thinking there's going to be one of these testing modalities that should be utilized. It's going to be a mix of modalities. And I do believe that there's a place for different types of testing modalities for different populations, for people at different phases of their life. So I think self-testing, for example, is not appropriate for everybody, but it may be appropriate for people that we can't reach now through available services, through facility-based services, through outreach by community workers and so on. So it's an option, and I think it's really important that we maintain the rational mix of options that are cost-effective, that meet the needs of the different populations, and also that are associated with better linkage and that are effective, that have a better yield. So I think in the end, there's no magic way of dealing with the whole challenge of knowledge of status. I think it's going to be a mix and needs to be adapted to the population and to the setting.
Before giving the floor to the audience, I will ask the panelists if they want to react or to add something to Wafa's presentation or something that you were trying to say and I didn't give you a chance to say it. Rupert.
I think that one of the points that Wafa made in the slides, I think you have to follow through the cascade if you really want to assess linkage. It's not enough to just go to the next bar of the cascade and understand what's happening. And I think we're seeing it with the implementation of option B and option B plus in pregnant women. So we can get very excited because we've immediately got 90% or 100% of women tested, and we've got 90% of those onto treatment, but we're seeing a huge drop-off, and we might be opening a door antenatally and then slamming that door postnatally. So I think it's important to assess linkage not just proximal to the test, but to assess all of those aspects of the cascade as we go forward. We can't only focus on one point in time.
Yeah, thank you, James. Someone else?
I guess,
Ken-
maybe
Candy.
Kenley, go.
Candy.
I was just going to also just weigh in on the issue of men. A lot of the people that are dying from HIV today are educated men, and partly because, and some of them are very good friends of mine who know about my status but would never go into a clinic to take an HIV test. So I think this idea of maybe promoting other alternatives such as self-testing might be a way forward, but it still creates how do we link these men into care? So I just want to leave it out there. It's a major problem.
Terry?
Okay. I was actually hoping that Ambassador Birx was still here because I wanted to address this, the age-free generation, because I was actually surprised that the U.S. is still really focusing on that tagline. I was recently in India, again, just the India thing, and saw the situation which I want to share. 60% of the marriages are still arranged in India, and this is what we're seeing over and over in our clinics. A woman gets married, gets infected by her husband, and the children also get infected. She dies. The father is left with an HIV-positive child. The father then, and this is what we see over and over, abandons the child at the clinic or an orphanage because he wants to get married to a new wife. And so he's going to marry a new wife, and he doesn't disclose his status, even though he is urged to disclose his status, and it's not happening. He dies, and the new wife ends up at the clinic, positive, sick, very sick, because she didn't know what was going on with the HIV-positive kid. And this was like over and over and over is what we're seeing in our clinics. So there's not going to be an AIDS-free generation in India or in any of these countries until we deal with the reality of some of these cycles. And the thing about focusing on age-free generation is they're going to be orphans. We're going to, if we have to save the parents and the 23 million people that don't have treatment. So I get kind of irritated when I see the focus on age-free generation, because what about the 23 million people that don't have treatment? Why do, they're going to be orphans. So the last thing I'm going to say is age-free generation, getting to 0, 0, 0, 0, ending AIDS, 90, 90, 90, and even ours, 20 by 20. They're all meaningless slogans unless we really activate a real response with a sense of urgency to actually take action. And I am, an absolute testing advocate. We can't do it. There's no treatment without testing. We need a worldwide, huge scale-up on rapid HIV testing.
Thank you. Rupert?
Yes. The topic for this afternoon, I understand, is generating treatment demand, which I think is a very telling title. To be brutally blunt, the best way to get more people to generate treatment demand is to get more people infected. And the best way to do that is to ignore the behavioral, mental, and social issues and these determinants of illness. What happens then when you get tested and you go into the clinic, and I mentioned before about the physician-centered model. However, if I unpack that a bit, what it is that that HIV is driven by behavior, and yet I don't know, and I have never come across in my own experience as a patient, any service that integrates behavioral medicine in with its biomedicine once you're in the service. Yes, you can get referrals to psychologists, okay, but that is for specific things, and often the referrals are of poor quality, and they're not taken up because it's not integrated. So and there's no reason why people either at risk for HIV who use STI clinics, for instance, shouldn't already have access to those services that then have the opportunity to have much greater impact in terms of prevention, either primary prevention or secondary prevention, or tertiary, obviously. But I think that if there's one thing that I want to bang my gavel at is this lack of integration of services and this continuation of a physician-centered model that, as I said, fails to address or to learn the lessons of the 80s and 90s. And that, I think, is going to be the key to dealing with the issue about linkage and learning to jump these gaps that currently exist.
We're going to take 2 questions from the audience, but first, Agwafa wants to have an additional comment.
I want to comment on your comment. I think that there are many lessons to be learned from Africa, to be honest with you, that are very, and I'm often embarrassed by how we in the global north are really way behind the response in Africa in particular. I think HIV prevention, care, and treatment is not physician-driven at all. I would say it's really largely driven by nurses who are from the same communities, who are really committed to the patients and to the families and do an enormous job under very difficult circumstances, and who are very attuned to the psychosocial issues and are really not as wedded to the medical model as maybe in the north, in the global north. I do also think there's been enormous work to integrate support services. I can tell you in at least the clinics that ICAP supports with the Ministry of Health, at every single one of them there are peer educators that are really providing the support, the navigation, the ear, the education to people who are newly diagnosed and people who are in care. So I do think we have a lot of lessons to be learned from the amazing response in Africa, and I feel like we actually haven't garnered as well as we should those lessons. In addition to self-testing, rapid testing, that all really were innovations in sub-Saharan Africa that have just come to our shores. So that's why I'm optimistic. I'm optimistic because the level of innovation, the level of commitment that I see in the countries where we support, I think demonstrates to me there are new frontiers that are being broken. There are new ways of doing things, and I think that's very encouraging. I don't think people are really stuck in an old model. They're really trying to move and innovate and learn and relearn.
Can I just respond to that? I agree with you, and I think that's very true. We used to have that in the West and the global North. Mm-hmm. Until '96, there was a lot of integration from the community. Mm-hmm. Then the biotechnology comes along, and it empowers the old model, which then the community gets pushed out of the clinics and disempowered, including the community-based organizations then become bureaucratic and doing for the community rather than with the community. Mm-hmm. So that's a lesson that I hope the Global South learns, and the Global North really needs to retain the lesson that we used to know, but we don't know any longer.
Okay, I think Kenneth is telling me that there is no time for probably one. Okay, one. Yeah, you can start. Start, please.
Hold on.
I think this cascade diet, well, first of all, I want to agree with everything that Rupert and you said, because back in the 80s, it was clearly shown that one-stop shopping in places for both prevention and care, supportive care and all kinds of things was much more efficient and resulted in a much more cohesive and adherence to the treatment schedule and much better outcomes. And that's without a doubt. The problem came when we realized that the people on the margins of society were not participating in those programs, and so we had to start fractionating them and delivering them in those minority communities, and they rarely had the resources allotted to them to provide that kind of services. But my comment is that cascade is a lovely diagram that you see in any business model or any bureaucrat can draw. But the idea that we can find data to fit into those artificially created segments of the treatment process that will apply across the board or will not vary from individual to individual, I think is totally ridiculous to me. And if one tried to run a global business and on the basis of that kind of a flow chart, I think you would go out of business very rapidly. And I think you have to take a much more sophisticated approach to what's going on, what are the environmental things, and most of all, what is the healthcare and public health infrastructure? Because it's failing, and you're just illustrating its failure. You're not explaining anything more than that.
On that provocative note, because we do have another panel coming up, I want to thank the present panel, Jorge and the other speakers very much. I think the point that David raised is an important one, and we'll discuss through the meeting, but